Good afternoon to everybody. This is the fourth and final webinar that we're having. And this is being conducted by the Center of Excellence, AIIMS, New Delhi, on monkeypox management with the Ministry of Health and Family Welfare. And we have also state officers from various states on board also to really help us and disseminate the information as far as monkeypox is concerned. We've had 3 talks before this on the global burden of disease and epidemiology, on investigation and diagnosis, and clinical presentation and management. But I think today's talk is very important because if we want to really break the chain of transmission, if we want to decrease the number of cases and make sure that monkeypox doesn't become an issue in our country, then prevention and infection control of utmost importance. And this was important for COVID, and it's also important for monkeypox. I personally feel that it's more important for monkeypox because this is easier to control and prevent. Like we discussed, the R0 is not that high as it is for COVID. And therefore, if we are vigilant and if we take good measures in terms of infection control and prevention, we will be able to prevent a large number of cases. It doesn't spread that much, unlikely to cause a pandemic, but we can have an endemic or an increasing number of cases. And we would like to avoid that. So today's webinar is very, very important. And we have Dr. Gagandeep Singh from the Department of Microbiology, and who's also one of the key persons in the infection control program of our hospital, who will be talking today on prevention and infection control, after which we will have questions and comments from the group. So without much ado, I'll ask Gagandeep to start the talk, and then we'll have questions later on. Over to you.
Thank you, sir. So today I'll be discussing related to infection prevention and control in the context of monkeypox. So the outline of my talk will be, I'll be discussing the basics first and then moving on to prevention in the healthcare setting, where I'll be discussing standard precautions and transmission-based precautions. And then I'll be discussing in brief how to prevent monkeypox if the patient is at home. So coming to the basics, monkeypox virus, as we know, is an enveloped virus. It's a DNA virus, and it has bearing on infection prevention and control, and I'll come to that shortly. And it can survive on inanimate objects for prolonged periods of time. Again, this is very important. Primary route, as of now, seems to be close skin-to-skin contact and rarely through droplets. And therefore, a combined or a combination of standard contact and droplet precautions in any patient who presents with fever and vesicular or pustular rash will be required. However, but because there is a theoretical risk of airborne transmission of monkeypox virus, especially if we are doing aerosol generating procedures, etc., so airborne precautions may be applied as per the risk assessment. If I talk about infection prevention and control in a healthcare setting, as expected, majority of the times the exposure is going to be in areas where these patients usually present, and that will be in clinics like the dermatology OPD, the medicine OPD, the eye infectious diseases clinic, and sometimes maybe in the emergency and other areas as well. So prevention can broadly be classified as standard precautions, and in addition, as I spoke, contact, droplet, and airborne precautions. Standard precautions, as we all know, there are minimum infection prevention practices that apply to all patient care. And this is the most important thing, is that it is regardless of suspected or confirmed infection status of the patient. So whenever we are interacting with patients, we need to perform or we need to follow standard precautions. And the basic purpose of standard precautions is so that the healthcare worker themselves don't acquire infections, and also infections are not spread from patient to patient. The components as given by the CDC and the WHO, there are multiple components of the standard precautions, and the most importantly, they are hand hygiene, respiratory hygiene, which is also known as the cough etiquettes, personal protective equipment, cleaning and disinfection, biomedical waste management, needle, stick, and sharp injury prevention, and safe injection practices. And all of these are important as far as monkeypox is concerned. Hand hygiene, I think a lot has been taught over the past 2.5 years. And we know that hand hygiene is one of the most important procedures for the prevention of any healthcare associated infection. So here also we are lucky that this is an enveloped virus. So alcohol is still active in deactivating the virus. So any alcohol preparation which has a content of 60 to 95% can be utilized. And if that is not available, of course, the age-old hand washing with soap and water will be as effective. We need to also remember the 5 moments of hand hygiene. The 5 moments are nothing but the opportunities whenever we need to perform hand hygiene. And this can be before touching a patient, before any clean or aseptic procedure. If we come in contact with any of the body fluids, then we should perform hand hygiene. After touching the patient and after definitely coming in contact with the patient's surroundings. And these should be always followed whenever we have one of these opportunities. Cough etiquettes again will be important in the scenario of monkeypox, because if at all you are exposed to a patient, or if you are exposed to a patient of monkeypox, we know that the infection can be transmitted through droplets. So cough etiquettes will be important. So you should ask the patient to cover their face. Even healthcare professionals should wear an N95, and hand hygiene, of course, is an integral part of cough etiquettes as well. PPE that should be used by healthcare personnel who enter into a patient who's a known patient or a suspected patient of monkeypox. They should wear gown, gloves, eye protection, which can be in the form of goggles or face shield. And I've already spoken about N95, that there is a theoretical risk of airborne transmission. So therefore, we are keeping our guard high, and therefore we are still recommending, all the international agencies are recommending use of N95 still. In addition, WHO does talk about use of dedicated footwear that can be contaminated, so that the footwear should be made of material that can easily be disinfected. And disposable shoe covers are not recommended, and they should not be worn. And this is what is told by the WHO. Sequence of donning the PPE. Again, I think we are well versed with this, but I'll just quickly go through it. The gown should be worn first, followed by the mask or the respirator, followed by the goggles and the face shield, and finally the gloves, be it sterile or unsterile gloves, depending upon what procedure you're going to perform. And while doffing, gloves, because they are the most contaminated, should be removed first, followed by the face shield and the goggles, the gown, and finally, while when you just come out of the patient area, you can remove the mask or the respirator, so that you, the healthcare worker, is at minimum risk of acquiring the infection. Now, coming to transmission-based precautions, all the 3 in combination should be used, and I'll be coming to the subsequent slides will include all of these. So, we get a lot of queries related to patient placement as far as monkeypox is concerned. So, whenever you have a patient with suspected or confirmed monkeypox infection, that patient should be placed ideally in a well-ventilated single room or a private room with a dedicated toileting facility. This is very important because ultimately it's spreading maximally through contact. So we need to avoid that. And that can be only if the patient is the only person using that dedicated toilet. And isolation room, or that area where the patient is housed, that should be, there should be a signage posted at the entrance indicated that contact, droplet precaution, and airborne precautions should be utilized, and the door should always be kept closed until there is a contraindication to that. And the patient should cover exposed lesions when others are in the room, and also the patient should wear a well-fitting medical mask to avoid any generation of any droplet which can transmit infection to the healthcare worker present in that area. Now, this is where the issue is more important. That if there are common areas for suspects or confirmed cases, what should we do? So, if in a single patient room, if a single patient room is not available, and if in a large ward or a large cubicle, multiple patients are being kept, so it's better that you consider cohorting all the confirmed cases, and they can be housed together. If at all that is not possible, if you have supposedly a common area for all suspects, then at least there should be minimum distance of 1 meter between the beds. All the patients should be masked. Curtains, if at all possible, should be there between the beds, again to avoid any transference of any droplets. And both the patients or all the patients should be provided with commode chairs if possible, so that they do not use or they do not share bathrooms. And if at all, even that is not possible, that you're not being able to provide them with commode chairs, or they are not being provided with separate bathrooms, which many a time will not be possible. So every time a patient or a suspect uses the bathroom, it has to be disinfected subsequently. And if the patient is eventually diagnosed with monkeypox, all the patients who are there in that suspect area, they should be evaluated to determine the exposure risk, and then they should be followed up subsequently for 21 days to see if any of them develop monkeypox. Patient transfer again is sometimes an issue. Ideally, it should be avoided to transfer such patients within the hospital. But if sometimes they need to undergo radiological procedures and they need to be shifted, so within the hospital, the patient should wear a well-fitting medical mask during transport. And any exposed skin lesions should be covered with a clean sheet, or they should be gowns with full sleeves so as to cover all the skin lesions. And during transport, a healthcare provider should go along with the person pulling the trolley with non-gloved hands. He should be able to open doors and push elevators, so that there is in no way there should be any transfer of infection from the trolley to the doors or to the elevators. And the receiving department, wherever the patient is being transferred to, should be notified in advance so that they are prepared with all the required precautions. So if we talk about outside the hospital, if the patient is being transferred from one hospital to the other or from the hospital back to home, so the patient has to be transported in a dedicated ambulance. And if there is if there is a separate chamber, the driver can just simply maybe wear a mask and a pair of gloves. But if not, then the driver should wear a gown in addition to that. And after the transfer, after wearing the PPE, whoever is cleaning the ambulance, they should clean all surfaces like the stretcher, the chair, the door handles with 1% hypochlorite or any other disinfectant that is available in the hospital setting. And also, because sometimes we have reusable blankets or curtains, they should be very carefully packed without shaking them, without fluffing them, so that no aerosols are generated, and these should be sent to the laundry for further processing, and they should be clearly labeled so that people or the person, whoever is receiving such a laundry in the laundry area, they should know that this is from a suspect or a confirmed case of monkeypox. We are lucky as far as the cleaning and disinfection is concerned that the virus is susceptible to majority of the commonly used disinfectants, be it alcohol, sodium hypochlorite, hydrogen peroxide, all of the quaternary ammonium compounds, and even phenols. So as far as environmental cleaning and surface disinfection is concerned, whatever you've been following in your hospitals, please continue doing that. The standard cleaning and disinfection procedures should be performed as per the hospital policy. Always, this is not only for monkeypox or COVID, generally this is the rule that all the surfaces should first be cleaned with detergent and water to do away with the bulk of the organic matter. And then you should use whatever disinfectant you are using in the hospital, and which has virucidal activity, like 1% sodium hypochlorite. And activities such as dry dusting, sweeping, and vacuuming should be avoided, again for reasons that are well known. Wet cleaning methods are preferred so that you would just contain the virus or material that is contaminated with it. And as far as monkeypox is concerned, as of now, special air handling is generally not required. Laundry management, because this is again going to be an issue. So soil laundry, whoever is handling in the ward area or the ICU area, they should be wearing proper PPE, and then only they should handle all the bedding, the towels, the personal clothing, etc. Carefully lift and roll the linen. You please don't shake the linen and the laundry, again, to minimize any aerosol production. And these items should be carefully placed into a designated container or a bag for transport to the laundry surface after labeling these. Again, now, once the laundry is there in the laundry area, so the workers in the laundry should again follow standard and transmission-based precautions, and they should minimize handling, in particular, again, avoid shaking of the linen and the laundry. They should wear gloves, apron or gown, respirator, as well as eye protection. And because we know that the virus is pretty susceptible, so even linen can be machine washed in hot water, anything above 60 degrees with the routinely used laundry detergent, and it can be dried according to the routine procedures, preferably at high heat. But sometimes machine washing is not possible and hot water might not be available. So it can be, as we were doing for COVID-19 also, the linen can be soaked in any chlorine-based disinfectant, like even 1% hypochlorite in large drums, and then they can be further washed as you are doing for the rest of the laundry. They can be rinsed with clean water and allowed to fully air dry. Special mention about handling of dead bodies, although I don't think so this is going to be a very common scenario, but if at all the hospital is dealing with the handling of a dead body of a case, confirmed case or a suspect monkeypox, so the personnel who perform post-mortem care of the remains should wear PPE, as we had mentioned above, the 4 components: the gown, gloves, the mask, and other PPE, and the body should be prepared following routine healthcare facility procedures, as we do routinely, for cleaning and containing any body fluids, and then be wrapped in a plastic shroud, so that there is, if at all there is any, if there are any secretions, they should not leak out. Wrapping should be done to prevent contamination of the outside of the shroud as well, and a change of gowns and gloves may be necessary. So if at all you think that there are too many secretions and your gown and gloves are getting contaminated during the process of handling the dead body, you need to change the gown and the gloves in between. And if the remains, they go directly to the mortuary, they should be placed in a body bag after being placed into the plastic shroud. And persons transporting the body should again be wearing proper PPE. Biomedical waste management, again, a very important thing to remember regarding this, that there are no additional changes in the biomedical waste management. Whatever we are doing in routine should be done for monkeypox. So you just need to, whatever, all the masks, any waste contaminated with crust, secretion, serum, or body fluid should be disposed in the yellow bag, and all the others, like anything which has high content of plastic, should be put into the red bag. There are no additional modifications as till date. There are no recommendations from the CPCB, any additional or modifications for the monkeypox. So one question which comes often is, if at all a healthcare professional, even after taking precaution, is exposed, so what should be done? So asymptomatic healthcare professionals, they do not need to be excluded from work. They can routinely work by, they can wear an N95 mask and proper PPE, and they should just be monitored daily for any signs of monkeypox, be it fever, rash, etc., for the next 21 days. If at all during that 21 days period, the healthcare professional becomes symptomatic, especially if the healthcare professional develops a rash, they need to isolate, they need to be evaluated and tested to rule out monkeypox. And if they have any other symptom other than rash, be it fever, malaise, body ache, etc., they need to be isolated for a period of 5 days, because it is said majority of the cases would develop rash within 5 days of fever. And if at all no rash develops within that period of 5 days, they again, they can stop isolation precautions after 5 days. Then coming in brief related to infection prevention and control at home. So how do you protect others if you are a case of monkeypox, or if there is a case of monkeypox at home? So if you live with other people and if the accommodation is big enough, ideally isolate in a separate room, use a separate bathroom, and if that is not possible, every time the bathroom is used, it needs to be disinfected by whatever disinfectant you're using at home. Clean hands frequently with soap and water or an alcohol-based hand sanitizer. Clean and disinfect frequently touch surfaces and objects with soap and water or any other household disinfectant. Avoid sweeping and vacuuming. Use separate dishes, cups, bedding, towel, etc., so as to not to transfer infection. Do your own laundry. Majority of these patients are going to be otherwise well, so please do your own laundry. And again, that can be done by machine washing using simple soap and water, and even hot water can be utilized. And keep your room well ventilated. It's important to keep the room well ventilated. So if by chance any droplets or aerosols are being produced, they can easily be washed off from that area. If you can't avoid, and if if it's a small house, if others are residing in the same room, try and cover all the rashes with clothing or bandages. Avoid touching each other. Wear a well-fitting mask. Open windows and clean hands frequently. In addition, infection prevention at home. You have to contain and dispose all contaminated waste such as dressing, bandages into yellow biomedical waste disposable bags and hand them over to any local body, whoever is managing the biomedical waste. And no visitors should be allowed at home. And again, because there is, we know there is a distinct link between animals and the transfer of infection from animals to humans. We do not know whether pets and domestic animals can act in transfer of infection. So pets and domestic animals should be excluded from the patient environment. So just to summarize, standard and contact droplet precautions should be used by patients whoever has a fever with vesicular or a pustular rash. In addition, airborne precautions should be used in any healthcare setting. Isolation precautions until all lesions have crusted and those crusts have separated and a fresh layer of healthy skin has formed underneath should be followed. Thank you so much.
Thank you very much, Dr. Gagandeep, for the excellent coverage of prevention and infection control. I think these are very, very important steps that one should take. Although we have become well versed with many of these steps because of COVID-19, it's still very important that we re-emphasize these. And like we had discussed in the beginning, that there are two clades which have been described as far as monkeypox is concerned, the West African and the Congo Basin clade. There is also this theory that a new clade may be emerging, which may have more, the virus may now have a little bit more susceptibility to human spread, because the previous two clades were not that, most of the cases were those who had contact with animal, and human spread was uncommon. And that is why infection control and prevention now becomes very, very important, because there is a possibility that if there is a new clade or a new virus that is causing these outbreaks in different parts of the world, because of the capacity to have human spread. And we need to follow precautions. Standard precautions are something that we should follow as a routine now, with a large number of infections emerging. And it's not only for COVID-19 or for monkeypox, but even for infections like H1N1, where during this time of the year, during the monsoon months, there is an increase in cases. So standard precautions like hand hygiene, cough etiquettes, wearing a mask, I think are equally important now than ever before. And this is very important for healthcare workers, because we form the force which will manage a large number of these patients. And if the healthcare workers become ill, it becomes a big problem. Wet cleaning is very important, and that was also emphasized by Dr. Gagandeep. And I think we need to really look at issues like home isolation and what else we can do. I also have Dr. Somesh with me from the department, professor in the Department of Dermatology. Before I open it up for any questions, are there any comments that Dr. Somesh would like to make?
Yes, sir. So I came across, because I was, it's an interesting story. I was part of a UAE Derma group on a social media. So suddenly in the month of April and May, they started reporting a new kind of sexually transmitted infection. So what these patients were presenting like, they were having initial lesions on the genital coming with a fever, and the initial lymphadenopathy in the inguinal region. So they were wondering what is going on. And all these patients had a contact sexual exposure, a kind of risk behavior. And many of them were MSN, but some were also heterosexual and had a history of contact with sex workers. So eventually it turned out to be an epidemic of monkeypox, because they started this epidemic earlier. So now we can imagine what is going to happen in India. So they have constantly increasing number of infections reported, and 90% of them are through sexual acquisition. And I suspect many of those who 10% in remaining 10%, it may also be part of, there may be a sexual route of acquisition. So that raises an interesting question. Is it a sexually transmissible infection? Now, I'm not saying sexually transmitted infections. Sexually transmitted infections are those which are predominantly transmitted through the sexual route. But here the case is different. And as Dr. Gagandeep said, that it can be transmitted through the droplets or skin-to-skin contact. So we cannot take any chance, and 100% precaution in the form of PPE kit and isolation of the patient is to be done till we find out that whether this new strain is exclusively being transmitted through the sexual route. Now, it has been isolated in the rectal fluid, it has been isolated in the semen, and it has been isolated from oropharyngeal fluid also. So possibly it can be transmitted through the droplet infection, but also skin-to-skin contact remain a potential transmission risk. So if it turns out to be a sexually transmitted infection, then eventually in future the isolation may not be required, but we cannot reach to that conclusion till we get the more data, because WHO has refused to label it as sexually transmitted infection till now. So then I requested them to send the images of those patients who are positive, PCR positive for monkeypox, and they send me some 200 images. Every patient had a similar story, starting in the genitals and then spreading to the rest of the body. Initial inguinal group of lymph node is involved, but those who had orogenital contact, it started from the lip or tongue or around the mouth, and they had a cervical group of lymph nodes. So it's a bipolar distribution. If I had some information earlier, then I would have brought you some photographs. They look so striking, and not like any other disease, but they can be mixed with chickenpox, hand, foot, mouth disease in children, which is getting very common these days, and some other infections. But the picture is very, very striking. And more till we get the more data on transmission, then we will be able to get to some firm conclusion whether it is transmitted through the sexual route exclusively, this new strain exclusively through the sexual route. And this, in the historical terms, it has happened with syphilis. Syphilis was an endemic disease in most part of the Asia and Africa before it became sexually transmitted. So this can happen. It is originated from Africa, and again, it can become a new strain, can become exclusively sexually transmitted, but it's still too early to say because WHO hasn't said that. But we know what we know from the facts is that more than 90% transmission is through the sexual route in majority of the countries. Even from Spanish data has come, which is on the same lines. But we should not stigmatize anybody till we get the more data. And if it is proved to be sexually transmitted, then stigma will come into the play, which we should strictly fight against for. So that's all about, sir. Thank you.
Yeah, so thank you very much. We've had a detailed discussion on this on the first day also, that this currently, although the paper in NEJM also showed that more than 90% of individuals who they had monkeypox were MSM, men having sex with men, and I think 40% of them were retroviral positive. We still can't say that this is a purely sexually transmitted disease, and this is what we had said, that close contact is more important as of now, because this is the data which has emerged from the previous two, the other clades that we have. This third clade is something that is being currently looked at. But currently it is felt that this is more a derivative of the West African clade, which causes a milder illness, has low mortality. And there is now more data evolving, so we will get an idea over the coming months. But as of now, it is not a sexually transmitted disease in the true sense. It can be transmitted through sexual contact, but also through close contact and through droplet infection if there is close contact. So unlike COVID-19, where the infection could spread rapidly even if there was not that close a contact, this needs a close contact. This needs contact with the skin surfaces, especially when the rash is there and it's before it is crusted and fallen off. And therefore, we must insist on all the precautions that should be followed in terms of infection control both in terms of droplet infection, close contact, and sexual transmission. So I think this is very, very important that we highlight all of this, because we should not go here with the message that this is a sexually transmitted disease and we shouldn't follow any of the other precautions. That is not true. There is enough data to suggest that monkeypox, as it has spread in Africa, can spread through droplet infection and also through close contact. And we must take precautions as far as this is concerned. If data evolves, then we will see how things are. As of now, we need to really look at whatever data we've had. We've had outbreaks in 2003 in US and in Nigeria in 2017, and all of them were linked to close contact and also some degree of droplet infection. This may be a little bit of a variation because of the data which has emerged, but then there is another school of thought which feels that this may be the early reporting which occurs in a community which does have close contact and are more health conscious and therefore are being picked up more. And you may have it in the community where people are not coming forward to get themselves tested because it's a self-limiting disease. And as has been mentioned, sometimes it's just fever with a mild rash, and people feel that this may be just some degree of viral rash. They don't suspect this could be monkeypox, and therefore it is not reported. That is also something that we need to highlight, because in the beginning, it was highlighted that the history of travel was important. And even if you look at the ministry guidelines, one of the criteria is that you have traveled or come from an area where monkeypox is present in the last 21 days. But we've heard from the various people in this group who have actually seen cases in our country, both in Kerala and in Delhi, that a large number of cases did not have a history of travel. And therefore, I think you should have a high index of suspicion, get the test done. But all cases with fever and rash are not monkeypox. It's still a rare disease. That's also something that we should keep in mind. And we are not seeing it frequently, and therefore there is no need to panic, and we should have just a high index of suspicion so that the infection control is there. So I would actually say you just follow standard precautions in infection control as we would do in routine, and don't create a panic situation. So over to you, Rajiv, if there are any questions or comments. And if anyone in the group who is would like to give his comments, he can just put the video on and give their comments.
So we have just one question at the moment, and this is about pregnancy. So anything special that any comments about pregnancy and monkeypox?
So there is some data, and maybe Dr. Sumesh can then add on to that there can be transmission from infected mother to the fetus, and we need to be careful about that. We need again more data in terms of how the disease will evolve, in terms of what can happen. But if you look at the criteria for those who have a high risk of more severe disease, pregnancy, lactating mothers, and even children less than 8 years has been mentioned along with immunocompromised people. So I think it is extra precaution is required in pregnant women. Dr. Sumesh, anything from your side?
So and especially it becomes an indication for cesarean section if the woman has lesion on the genital, inguinal region, and inguinal lymphadenopathy, because we know that this is transmitted through the contact, skin to skin contact, and any fetus coming into the contact with the secretions in the genitals or perigenital areas, then it become a problem. However, there is no data so far. And even data for pediatric population is almost non-existent. There are very few cases, if at all, reported from other parts of the world. And this, we should remember that this disease has been reported for the first time in 70 countries, first time ever. So still we are, evolving in our knowledge, and we don't have much data on pregnant women and children.
So I would just say that whatever data that we are saying is extrapolated from previous outbreaks in with monkeypox, which happened. The number of cases actually have been very few till 2003, and they've increased only over the last few years. And one outbreak in US, and then in Nigeria, where the cases were more. Otherwise, there's been just a handful of cases being reported over the years, and therefore the data is not that robust enough to really say that this is can cause, or what are the effects that it can have, both in terms of pregnancy and in children. Whatever is there is extrapolated from the previous data. We don't have enough data from the current outbreak as to how it will behave, but I'm sure this will emerge over a period of time. Hopefully, we may not have a large number of cases. What is only a cause of concern, which raised the red flag as far as WHO was concerned, that so many countries across the world reported cases of monkeypox for the first time. And therefore, it seemed that there was a higher chance of it spreading than what was previously seen, because predominantly it is a disease localized to Africa rather than the rest of the world.
We don't actually have any more questions, and neither in the chat box nor in the Q&A. It seems everybody's learned enough.
I'll ask Dr. Gagandeep if you would like to say anything in terms of anything you would like to reinforce as far as prevention and infection control is concerned.
So I think it's not only related to monkeypox, but generally I would reiterate what Sir has said earlier, that whenever we are coming, whenever we are coming in contact with a patient, so standard precautions need to be followed every single time, and that is what the background of standard precautions is, that it is regardless of the infective state of the patient, and all the standard precautions should be followed every single day whenever there is interaction with the patient, because that is going to prevent transfer of infection between patients and also from patient to healthcare workers and from healthcare workers to patients. So that is extremely important. It is not only that we are now that we faced with outbreaks like COVID-19 and monkeypox that we start talking about them every single day, even for prevention of transfer of multi-drug resistant organisms within a hospital setup. If we are diligently following standard precautions, I think majority of our healthcare associated infections would come down.
That's true. So I think these are important precautions: hand washing, cough etiquettes, wearing a mask for a large number of infections in the hospital. I mean, we keep emphasizing on hand washing in the hospital. But if you really go to the ward or to the ICU and you see the round going from one bed to the other, hand washing is not done as diligently as it should be. And you too tend to carry the infection and cause multi-drug resistant infection. Similarly, it's important for us to understand the importance of mask and cough etiquettes, even from the point of view of not only viral infection, but tuberculosis. You can decrease tuberculosis because it is also can be prevented by good cough etiquettes and wearing a mask. So I think these are something that we need to emphasize in day-to-day practice and make it a habit that we do this routinely rather than just focusing when we have an outbreak or when we have a sudden surge in number of cases. So something that one has been doing for many, many years, but I think it's become more important now. And therefore, I think this is something that we need to focus on. Dr. Sumesh, any last comments that you would like to make?
Yeah, so from the data earlier that the secondary contact transmission is 10 to 15% as against 90% in COVID-19. So if we are following all the precautions, the healthcare workers need not to worry about as we had with COVID. If we are taking precaution, wearing a PPE kit, and then we can take care of these patients without any fear of transmission.
Yes, so I think we're emphasizing this repeatedly because I think this is very, very important. And if you have one take-home message, that is that follow standard precautions and make it a habit in your day-to-day practice. This will help you not only from the monkeypox point of view, but in infection control in many areas, and try and inculcate this habit in your hospital so that everyone follows the same precautions. Any other comments or questions, Rajiv?
No, sir, there's nothing else that's appeared.
So then maybe we can have any comments from the Ministry of Health and Family Welfare, if there's anything they would like to say, because this is the last webinar that we have in this series of 4 webinars that we've had over the last few days.
We'd like to thank you, sir, first and foremost, the faculty and Professor Randeep Guleria, Director AIIMS, for this esteemed and this continuing webinar that has covered all aspects of monkeypox disease. We'd like to also thank the centers who had been kind enough to join this webinar, the series of webinars. and the regional and state centers for excellence, along with Indian Medical Association, Indian Association of Dermatologists, Venerologists, and Nephrologists, and their members who were participants of these webinars. I hope this will go in a long way, and the knowledge that was populated in this through these 4 webinars can be moved down to the state and the district level, and people can learn a lot exactly what is monkeypox disease. What Sir had said was very correct. Though the disease may not be so common, but at the same time, people should have the thing in mind that whenever we are seeing a fever and rash with some kind of a travel history from a monkeypox and countries, coming from a monkeypox countries in last 21 days, people should have a doubt and then they should search further. And isolation remains the key. And second part is the symptomatic treatments. As of now, India is still following the symptomatic treatment followed with isolation. We don't have any kind of a vaccine or at this juncture, drugs at this country, which has been recognized by DCGI and which has been utilized in the market. And with that note, I just like to thank each one of you for joining this particular webinar. And I give back to Guleria sir for his final comments.
Thank you very much. I think we've had these 4 seminars where we've discussed the global burden epidemiology and how monkeypox has evolved over the years and the impact that that we've had, and some theory that because smallpox vaccination was stopped, the protection that smallpox vaccination was giving us may also be a contributing factor to the increasing number of cases over the last 2-3 decades. We've also had a whole webinar on investigations. What are the investigations? How do you collect the sample? How do you transport the sample? And what are the forms that you need to fill? And how do you make sure that it goes? And what are the sites? The 15 sites in the country which are doing testing for monkeypox were also put up, and that is available on the ministry's website also. We also had a discussion on the clinical management, the presentation, the incubation period, the prodromal, the pre-prodrome, the prodrome phase, and what are the manifestations that should make you suspect monkeypox, both in terms of the skin lesion and, as was mentioned, that we are seeing genital lesions and oral lesions also, and what can be the differential diagnosis. The management continues to be supportive. There are some antiviral drugs which are available. We discussed that also, the role of vaccination, the 2 types of vaccines which are there, the role of immunoglobulins. And then today we've discussed what we should do in terms of prevention and infection control. So if people have missed out on these webinars, they are available on the YouTube, and they can see them in a comprehensive manner so that they can really get an overview from the global burden epidemiology to how do you investigate, the clinical presentation, management, and infection control. So thank you very much for logging in, and I thank the Ministry of Health and Family Welfare for organizing all of this, and the entire team for being here. I thank my faculty colleagues who've been coming every day to really answer questions and take part in these important webinars. Thank you very much.
Thank you, sir.
Thank you.
So